Recording in progress.
السلام عليكم ورحمة الله. أسعد الله أوقاتكم يا رب بكل خير. Welcome all. Thank you very much for being with in wound care diploma. Is there any question or any concern? في أي سؤال أو استفسار about what did we discuss last time? In the last meeting, we already described the wound measurement, the wound assessment. So we know what are the steps that the wound will pass through. You know how we will describe and use the wound care languages. In this case, we will be able to transfer the information about the healing progress. Is now the wound in a proper status or a proper condition that will make or reflect the proper decision in the treatment protocol. Today, inshallah, we'll start with a short topic related to the wound measurement or the digital wound measurement. In the last lecture, we already said how we will describe the diameter of the wound from 12 to 6, from 3 to 9. Important here to notice that in the European scope of measuring the wounds, we are fixing from 12 to 6, 3 to 9. While if you are dealing with references or from scientists, scholar come from the North America and Canada, you will notice little bit recommendations from their own point of view to take it from the longest way, regardless if it's from 12 to 6 or from 3 to 9. So you will measure the first number will be the longest. Anyway, we are still following or affiliated with the European scholar in our region. That's why we will keep fixing our measurements for the wounds to be in the ways that talking about the diameter of the wound. So if we would like to describe the 3x3 methodology of wounds measurement, so if this is the wound in this way, so at any time, any point, referring to the 12 will be to the head of the patient, and referring to the 6 will be to the toe of the patient, and the measurement or the first number of measurements will be the distance from 12 to 6. This is a part of how we are dealing with the assessment of the wound. But last time also we focused while we are describing the taking photos for the wounds or taking pictures for the wound, that we are described that photo, some human take it for another human. But what about the new trends about adopting the AI and the software and what's known now in the world of the wound care, the digital measurements for the wounds? When we hear this, the term digital measurements in the wound care, this is referring to using technology. And this technology started at the beginning in measurements and give assessment to the second level of monitoring the wounds, and even now to suggest treatment plan for the wounds based on photo or software that given for a computer or for a device, and this device already trained in a way that can suggest treatment protocol. There are a lot of digital tools, and there is a huge evolution happened in the last years, and there are also variations in the consistency, efficacy, and the precision or the accuracy of the suggested decisions. Let's here start to understand this concept as the digital measurements in the wound care and the adopting of the technologies for the purpose of assessment, monitoring, and suggest treatments. There are some important components or types. We can classify the available software in the field. There are the normal way that what we already familiar with from the last meeting, which is that taking the photography. And in this case, they connect the photography or the picture to the electronic medical records, such as Hakim, Sahati, Cerner, Al-Shifa, regardless of what are the type used, the EMR, electronic medical record used in your facilities. And these photos will be under the patient records. And then the wound care nurse or the doctor can start to follow up the changes or consequence and series. In this case, the only things that done that we just take a photo and this photo uploaded to the system. The advances happen after when they start to suggest the 3D imaging for this wounds, for these wounds. In this case, they are using the camera and also another kind of software. In this case, they start to calculate space, the amount of tissue loss, and so on, and describe it for the review of the healthcare providers, and then determine what are the type of tissues in the wounds and what are the conditions that will be happening. In the following period, there are advances happen as in software facilities or software options. In this way, they start to dive in making image analysis. In this image analysis, the softwares measure the dimensions, the length, the width, the area, and also they train the software on identifying the type of tissues. So the software will tell us, is this granulation tissue? Is this necrotic tissue? Is this slough? Is this fibrin? And also estimate the percentage of each type of these tissues in the wound bed. And also, because the software is started to develop with a good amount of memory, so they will develop healing progress track, and this tracking will give for the practitioners assessment for efficacy of the treatment plan. Are we in the right path in the dressing or not? And also, these software start to be advanced more, to be apart from the smart apps. So there is some application that can be adopted or utilized in the field of the wound care by using smartphones, either the personal smartphones for the patients, their own families, or specific devices that will be available for the practitioners. So either it will be in a specialized device or by smartphones. The advances is that by connecting this information to the EMR or EHR, the electronic health records, and there is a kind of integration, and this integration will allow the right of the patient to take this information from the software to be reflected in the patient's documentation. And also it helped during the time of COVID in the remote monitoring for the progress of the wound care for the patients when they are away from the healthcare facilities. Anyway, this is in general how it's going on. Our target is, because now we are expecting more and more adopting for the machine learning principles or AI, that what we are now start to be familiar with in the field of the wound care. It's important in the wound care here to understand the principles of developing these softwares. Of course, we are not expecting, or it's not expected from us that we will be a programmer or make the software, but we will help the programmers in developing and advancing the current softwares, the current applications in the field of the wound care. So we will come to see the experience of the previous software's development in the field of the wound care and how they adopt the AI tools and how they already utilize the machine learning principles and the artificial intelligence in this field. If you are people working in the wound care in the end of 2016 to 2017, at that time there was a trend in the field of the wound care by collecting the wounds photos. So there are a lot of platforms that they are collecting photos for the wounds, and they were paying some money as a reward for anyone that upload these photos in these platforms. What they were aiming to, at the first stage, they should identify the problem. So we should think in the mentality of the wound care nurse, as we will come now on the coming sections for the wound bed preparation. If you see a wound, as a wound care experts, how do you think about this? What are the strategies or the mental process that you will adopt it until you think about this one. So you think about the assessment at the first, and in this assessment, you make some notes and comments, and you are already following a structured way of doing the assessment. Then after that, you will come to make a decision about the requirement for these wounds. Then after that, you will make treatment protocol. So in this treatment protocol, you choose the dressing and so on. This is what they call it here in the wound apps, that identifying the problem, or what are the steps that someone will looking to determine the issues. For example, in the world outside the healthcare field, you're already using the Gmail. So the Gmail had a system inside that determine if an email is a spam or not. And this adopted by regression problem. Let's come back here to our issues. After we are seeing the photos for the patients in day 1, then photos for the patients in day 2 or the second one, then photos in number 3, and so on. So after we have this database, they start to teach the computer that until we reach to the status in third photos, the wound should pass through the second photo. And until they will reach to the second photo, they should pass through the first photo. And they start here to define the characteristics. So what are the characteristics of the wounds in first photo? What are the characteristics of the wounds in photo 2? And what are the characteristics of the wounds in photo 3? And there are a lot of KPIs or indicators here, or factors, or variables. In this way, from the mathematical point of view, or from the statistical point of view, they will adopt the regression. And they will come here to conclude in these issues that until we reach to this variable, so by force, there are another variable should happen, and these variables also should happen. In this way, they're able to determine, for example, if the email written in specific way, this email will be going to your inbox, or it can go for spam. Now, maybe the same email can be sent to 2 people. One of them, the Gmail will understand that for this particular person will go for the inbox, while for the another particular person will go for a spam, because they understand that the first person, the kinds of email that received had a specific ways and a specific characteristic or features, and these features means this email for this person will be inbox, for this person will be in spam. In the same way, they adopted or start to do it in the field of the wound care. In this case, they are able to determine that if the piece of information that's coming from this wound will pass through this process. So if the wounds have this characteristic, then it will be in a pressure injury. If the wounds have this characteristic, then they will be in a diabetic fault. This is done automatically. So without interruptions on the system. The system has been trained in this way. After that, they will go for a huge database, and that's why the issues of uploading the pictures and photos for the wounds come in, because they would like to collect and confirm what the system learned. So the system will start to test this on information. So they will give different kinds of photos for the software, and then the software will determine, is it pressure injury, is it diabetic fault, is it infected wound, is it granulation, is it hematostasis, and so on. So this will be confirmed the parts of the information. In the second or the third phase, the system will be trained to clean the data, so they will be responsible to determine which photos already repetitive or not, which photos already the features of this photo or the stamp of this photo had been passed through the system or not, and then they will transfer and make the second ways of preparation. And wallahi, if you see a wound in these features, so you should give the decision to be in this statement. So if you see the wounds coming with infection, then you should do tissue management. Infection, then you will give antimicrobial management. If the kind of photos that you are seeing is necrotic or slough, then you will go for tissue management. If it's granulation, then you will support the epithelialization, and so on. So this is the parameters, how it's already. The majorities of wound care softwares in this digital measurements or the digitalization of the wound care followed a methodology called supervised learning. So they already specified what are the kinds of information that this software should learn on. And when it's already launched, the software will not be able to teach himself or teach itself by its own. So it will reach to a level, and this level will be in need for the programmers again to reschedule the updates on the system. And this is a part to assure the safety, because if it's come to unsupervised machine learning, they will not be sure exactly how the wounds or how the software will lead to treating those. This is a photo that can present how the software that understand and measure the wounds, they already take these points, and from these points, they're able to determine the depth of the wounds, how are the variations, the variables that are around the wounds, and what are the ways that will be able to conduct the ways of the decision and the assessment. Anyway, why we come here? Because it's apart from understanding this software building, it has or it assumes others what they think about the wound care. So, or others information, or maybe they use the expert's point of view in making these assumptions. But we should take in consideration presence of weaknesses in this system, and also the needs for continuous updates and continuous monitoring for its products. And until now, there are ways to determine or saying about the precision and the accuracy of the decisions come from. So the validation is important when we are talking about these softwares, and to not take the decisions come from these softwares as apart from guarantee information, and we should define the softwares in this way. Now, what are the available systems that can be or already adopted in the field of the wound care? We will go here for the examples. So the first company started about talking this was Swift Medical, sorry. And the Swift Medical, they provide a kind of apps. This apps is available in any smart-based device, so it can be used on the mobiles or iPad or tabs, and it will work in the following way. So it started or launched in 2018, 2017, end of 2017, and it will give you the photos in this way. So it takes photo for the wound, and then the software trained to analyze the photos that we're already seeing and give you parameter estimations and analysis for the tissue type. And based on that, you take the decisions in this way. It followed after that by the leverage AI technology, which is called the tissue analytics. In this tissue analytics, they adopt or advance the Swift softwares, and they used a different technology in the building of the software based on the JavaScript. And in this ways, they have also another features that they are providing or announcing that they are able to give accurate wound measurements through the automated edge detection, better classification, comprehensive documentation and tracking, and easy integration with electronic medical records. And it will come, as you can see here in this photo. So it used on a specific portable device that will be given to the practitioners, and it will highlight the changes happen, the parameters, and track this information to the patient file and the patient records. The eCare inside also, they have another softwares that build in a different way that rely more on the 3D reconstruction of the wounds, and they assume that they are providing better pictures, high quality information, and detailed analysis of the tissue dimensions, tissue type segmentation, and also abilities to integrate with EHR. This is an example of how its eCare insights come. This is how the photo can be analyzed and give information about the kinds of the tissues and taking in this information. Now, from our perspectives, we are expecting in the coming years more advances in these softwares, and our responsibility is to be the communication points between the wound care practitioners and the software applications in this way, and adopt the information that we are taking, adopting ourselves about how we are thinking in defining and also the type of the tissues, treatment protocols, and also to guide the programmers on how they will provide the suitable information about the treatment protocols. There are several techniques and tracking can be done to assure the ability of these softwares in providing accurate volume calculation, diameters, and tissue classification. And in the wound care, the tissues type or the kind of tissues that we can see in the wound bed can be much more integrated and getting mixed with each other. Also important in the field of the wound care that we are looking to keep the integration with the EHR. Now, the healthcare system are all transforming from being in a paper-based documentation to be EHR, and even the EHR is going to get much more advances in the way that already provided. For example, in Jordan we have Hakim, in Saudi also Sahati, in UAE, in Qatar, the Cerner are the leading, and so on. And each of these systems has its own feature and characteristic that we should be ready for the changes in the future in this. In this case, in this situation now, we finish the first aspects related to the wound assessment and preparing ourselves to the nature of wounds that we are dealing with. And now, understanding the cornerstone that changed the nature of the wound care practices, which is wound bed preparation. But before we go there, is there any question or any concern? في أحد عنده سؤال أو استفسار؟ احنا بنكون هلا في آخر مراحلنا في الانتهاء من assessment of the wounds, and now we will go for or we will take an overview on the wound bed preparation. If you remember in our, let me just put the slide. Okay. If you remember lecture on the wound care, we already take an overview about the development points or the cornerstones in developing the wound care. And we stop on the moments that change how we already deal with the wound care, which is the moment of creation, the wound bed preparation. Now, how we will work in this module today, we will take a panoramic overview about this theory and the model. And while we are describing, we will come in the following lectures to take each part alone and explore it. So it's important now to be mentally connected with us and prepare yourself now to the diving of the new updates in the wound care. We already said the first principles of this model that we are treating patient as a whole, not whole in the patient. The wound bed preparation transformed the mindset of the people from focusing only on the injury to check for all patients' condition. And they will classify the wounds based on that, on an indicator called healability or heal ability of the wound. To which extent that I can go in this wound with a purpose that this wound will be healed, or my purpose is to make sure the case of the patient or the wounds will not deteriorate to the worst. And based on that, this is what I'm sharing now. This is what's written in the special consideration, the wound bed preparation, and in its update 2011. Anyway, the first appearance for the wound bed preparation come from the HUMA conference 2003, and then followed by systematic review, and then the several updates happened, but the same concept still in this. Here we can see that the wounds will be classified to three categories. Based on these categories, our decision will be changed. So if the wounds here healable, so the condition of the wounds means there is a blood supply. The body as a body able to provide the suitable tissues for the healing to happen. In this way, I will evaluate the suitable wound care that it will reach me to the final closure for it. So I will come here to say that this wound it's already closed or fully healed. For unhealable wounds, my purpose will just to keep the wounds with no additional deterioration. So I will not reach her, or I don't aim to reach the points that these wounds will totally close. But I will adopt that the quality of life for the patient, that these wounds will not make the patient to go for another infection, such as septic, or to give this patient to be an odor or smelly wounds, so on. And there are the categories of stagnated or maintenance wounds, which is coming between. There is some factors pushing the wounds to be inhalability, and there are other factors pushing the patient or the wounds to be in non-healability. What are these factors? Are systematic factors or patient-related issues, such as the blood supply, the circulation, and so on. And always remember, if there is no blood, there is no wound healing. So if there is no blood, no healing. And now, based on this one, I will evaluate the patient condition and end by categorizing the wounds, either to the healable, stagnated or maintenance, and non-healability. And this is the author's name or the main authors of the wound bed preparation. And these are the famous names in this field, such as Dr. Gary Sebald, Dr. Goodman, and Kevin Wu, and so on. So after that, this is the first one in the wound bed preparation. We will determine the healability based on the patient's condition. So we will go then to the abbreviation or the famous abbreviation in the history of the wound care, which is TIME, T-I-M-E. In this abbreviation, they create these letters to reflect a kind of focus that the wound care will work on. Now, this kind of focus will be on the three levels of, or the three categories of the wound. So in the healability, I should manage the tissue. In the stagnated, also, I should manage the tissue. And in the non-healability. T here refer for tissue management. I refer for the infection management. M refer to the moisture management. And E refers to the wound edge or epithelialization. And they assume that you cannot jump on the points without taking care of the previous points. So I cannot jump to focus on infection management while I did not manage the tissues in a proper way. I cannot jump to manage the moisture that without taking in consideration the T and I. So here we will come to take about the progress or the development of the wound bed preparation birth. As we described in the history lectures, that the 1962 or in the 1960s, when the wound, the wet, dry to wet wound or moist wound healing theory appears to control the fields. And at that time, the main principles and simplicity assume that if the dry wounds or if the condition of the wound dry, so please make it moist. And if it's moist, so please reduce the amount of moisture. But after that, the field of research is developed, and to create another features and another ways of looking for the principles of the wound, the micro environments in the wounds. That looking for the condition of moisture alone did not reflect the actual situation happening in the wound bed. There are different sets that change the wound's condition. And they end by the definition or creating the concept. The first time appeared in 2003, which is the wound bed preparation. We are not going only to manage the moisture, rather than we are talking about comprehensive factors inside the wounds need to be prepared. And that's the first concept in the theory, which is the name of the theory, wound bed preparation. What is the wound bed preparation? If someone asks us, what is the wound bed preparation? It will be us here to use the definition. It's a holistic, the first principles. So it's more than one variables, and systematic. So it's passed through standardized way. And this holistic and systematic approach will evaluate. So it's apart from the assessment. And remove the barriers. And this is why we say in the theory of wound healing, or the normal wound healing process, our responsibility to maintain normal process, which start from hematostasis, inflammation, granulation, and modeling. But the wounds pass through one phase and get stuck. So the responsibility of the healthcare providers is removing the stuck that happened, or help the wounds that stuck in one phase to go to another phase. And barriers to the healing process, which is allow the wounds to progress the healing normally. It guides us through strategies, treatment strategies, targeting the patient general and the underlying condition. And in this systematic approach, we will be able to evaluate the treatment protocols and make a ways of standardization for the communication between the people. The concept of the wound bed preparation in the words of science, still it's new, and we are talking about a concept that originated or started 2003, a big changes or another understanding and deep overview happened 2003. So still this concept is new, still evolving the field of the wound care, and a lot of studies and research is going on, and we don't know the futures now with the AI, how it's already happened. This is Dr. Gary Sibbald, and he's one of the key leading factors in the field of the wound bed preparation. This is the original study that published 2003, and it represents this concept for the first time, and it's coming within this ways. The wound bed preparation, a systematic approach. So there is a specific system that will be followed in dealing with the wounds, and they transfer. So, and they in this study they transfer our ways of dealing with the wounds to be in a systematic ways. So there are specific protocols that we should solve it, and they, instead of taking about care only, they start to use the management for the wound, as it's not only a specific set of interventions. The first author in this approach was Dr. George Swartz and Dr. Gary Sibbald and Elizabeth Ailo. Now, the book that we are using in our diploma, it's written or prepared by Dr. Elizabeth Ailo, and all other of the names here are the key factors in the world, or in the scientific committee or ad hoc committee for the wound care. What did they notice in their own review? They noticed that the kind of something happened inside the wound bed, it's passed through a ways until it's happened in the process of the wound healing. That the wounds will start with, anyway, this already the initial phase of this description, but after that in 2011, it's coming to discover more or give more information about the cytokinase, and this is what we call it before the main players in the process of wound healing. And when one of these main players or one of these components stuck, they stop all the healing process to go, and this is what they do it or suggested to be the chronicity of the wounds. So this is the growth factors and how already members of these growth factors, the source of action, this is whom already produce these factors and what are the impact of these factors. And if one of these sources or any of these growth factors either increase than its limits or decrease in its limits, will stop all the process and lead for chronicity. That's why they change and modify the definition of the acute wounds, if you remember, with the chronic wounds, that before this theory, if any wounds did not heal within 21 days, they call it chronic, and then change it after, that any wounds did not reach the 50% within the 14 days, that means this is the chronicity. And based on this understanding of the growth factors, and this is the MMPs type. So do you remember when we say about the proteases or metalloproteases, we said it's proteases, so it's not more one type. We are talking about more than 16 types, and now we are talking about 21 MMPs types, and each one of them already had its effect or impact in destroying the proteins. And what's happened in the chronicity, or describing their own chronicity, that there is a problem happen in the cytokinase and these growth factors that lead the wounds to stuck in these fields and unable to pass and through. And based on that, they classify, or the first description at that time happening for, oh, please, there are some wounds will not be healed, so we will go for antiseptic, we will go for more quality of life. But for the tissues management itself, they will start with tissue management. At the beginning, they call it debridement, so it was DIME, but then changed to being a tissue management, not only debridement, because the tissues can be managed in more than only debridement. Then the bacterial balance and loads, which is already transferred to be infection management, moisture management, and also the epithelialization or wound edge. This is how the clinical observation can be classified or determine the condition of the patient, that the barriers for the wounds to heal, the first barrier for the wounds to heal is the presence of unwanted tissue, non-viable or deficit tissue. If these tissues, that dead tissue stuck on the wound, will be the first barrier for the wound healing process to happen. Why there will be the first barrier? Yeah, why the body by its own looking to make autolytic debridement? If you have a dead tissue on your body, the body by itself will try to minimize its amount of these tissues and then extract it out. One of these theories suggests the presence of the base for the bacteria, so it will be in a source for infection or biofilm. Other suggest that it's weight that will make a pressure on the underlying tissues. So these tissues will be in need to get out this weight out. In all of this debate and discussion, they end that they should manage these tissues and remove it from the wound. The second variables in this observation will be managing the infection or inflammation. And we define that the infection is not inflammation. There are different differences between this one. Infection means the microorganism come in. Inflammation, it's a process of cleaning that the body will use to fight the infection or microorganisms and also to remove the dead tissues. Number 3 will be moisture balance, that the body will, or the strategies for the wound care should assure there is a balance in the moisture that will not allow for maceration and saturation of the enzymes in the wounds until they will lead to the epidermal margin or immigration of the epidermal cells. In general, in this study, they end up by the need for a specific guideline or specific steps that will lead us to use the proper dressings and allocate the dressing. So we will come to say this dressing will be used in the teeth. This dressing will be used in I. This dressing will be used in M, and so on. And there is no one dressing can be used for all these letters. We cannot jump between these letters. And also, this dressings, until now, of course, doesn't have brain. So these dressings have been modified, manufactured to satisfy specific purposes. And this make a great achievement in the field of research in the wound care aspects. The overall, after this study start to appear and making the changes, it's provide the aim of the wound bed preparation is to create wound healing environment and support the body to pass through the normal wound healing process. So this is what they did not assume that the wound bed preparation will help in healings, rather than it will support the body to maintain the normal wound healing. And after announcements of this theory, it takes several levels of debate in the wound care experts community to come by the underlying factors, impacts, and the ways that reflected in the dressing protocols, guidelines, governmental insurance, government protocols, insurance companies, and also for the new types of dressing start to originated and developed. Let's here to take it deep now for the component of the wound bed preparation. So we know that the wound bed preparation aim for systematic, right? So it's a systematic. So systematic way for what? What the meaning here of systematic? They say, until we deal with wounds, we should support these wounds to pass through the pathophysiological abnormalities by tissue management. So we should remove the unwanted tissues. Inflammation and infection control. So we should reduce the body's responses in the inflammation and maintain the wounds with a low effect of with microbial agents, and make the balance for the moisture. So support or taking the same what's come from the wound, moist wound healing process, and ensure the epithelialization or edge advancements. So in this case, we end or support the keratinocytes. When the keratinocytes come, we come to building the new tissues. And this opened a field for several researchers in this field, so that's why we have a lot of big aspects of the studies that come from. Now we will take a panoramic overview, as we said, over this time, and later in each lecture we will take each letter alone and see the evidences and the information around it. Some of these letters can take more than one lecture. For example, the infection, because we will split the silver lecture alone, the honey dressings alone, and so on, because there are some variations. In the epithelialization, because there are importance to know more about the normal skin condition, so we will take about the skin care, the cosmetics, and so on, before we cover the E part, because of its connected and effects. This is the abbreviations or the ways. At the beginning, it was, as we said, tissue debridement, and now it's tissue management. There are various ways for taking and defining the wounds based on the acute and chronicity, and the healability and non-healability, and each one of them will work on its own. Now, for the tissue management, if there is foreign bodies, so this foreign bodies itself will be the unwanted particles, so it should be removed until these wounds will heal. Now, if this bad tissues or the dead tissues coming from the body himself, from the same or originalities from the same patient, so this tissues should be taken out, crushed, debilitated, and so on. The famous or the most ways or easy way for making this tissue management is by sharp debridement. So the concepts of debridement mean removal or taking out. But this ways of making the sharp debridement getting to report important deterioration in the wounds, mainly for non-healable and stagnated or subacute wounds. What that means? If you notice any doctor after surgery or after debridement, because of using the blade, it will lead to bleeding. But what's the problem? Okay, let's the patient bleed, little bit blood. Oh, the problem is not in the blood that will bleed. The problem that we shift back the wounds condition from current phase, which is inflammation, most probably, to hematostasis. So there are 4 phases the wounds should pass through until the wound healing happens: hematostasis, inflammation, granulation. Now, when there are unviable tissue, the doctor or the surgeon or the wound care, when they're using sharp debridement, they will come to make the debridement by the blade. But because of inability to determine exactly where is the bad tissues start and the healthy tissues come in, maybe some overlapping will happen, so you will see the blood. In this case, the wounds transferred from second phase of wound healing to be in the first phase. So we deteriorating the wounds. Okay. The theory says that in this condition, if the patient unable to send or provide the suitable amount of blood to the wounds, that means the patient will only lose tissues and unable to attract or build the new tissues. So what we are doing now, we are just making the wound bigger, expanding the depth of the wound. And there are a lot of factors can lead for inabilities of these wounds to pass through the healability condition, or inabilities to provide a suitable amount of blood or suitable amount of factors to the wounds condition. It started from the systematic factors, systematic reasons, as diabetes, anemia, malnutrition, insufficiency. But the surprising information that there are also other factors inside the wound can lead for more death in the tissues happen in the wound from the wound himself. Such as what? Such as the necrotic tissue. The necrotic tissue maybe start with 1 centimeter. If the patient's condition or the patient's situation is able to deal with this 1 centimeter of necrotic, after some days you will see this 1 centimeter necrotic now 2 centimeters or 3 centimeters. Or it will start to be surrounded by sloughs of the tissues. So what's going on? It's like there is failure in the wounds, and the wounds producing something that leads not to remove the previous tissues, but to produce another tissues, such as the enzymes, such as the exudates, the ability of white blood cells, and so on. And this is all lead for additional necrotizing or necrosis in those. And based on this irritation, that when the bad tissues happen or the bad tissues already in the wounds, the priorities of the experts or the healthcare providers is managing the tissue necrosis. So the wound bed preparation, we are aiming to T, tissue management, I, bacterial balance. And maybe now the people will ask, why bacterial balance? We don't want bacteria. There is no chronic wounds without bacteria, but we would like to reduce its impact. Avoiding moisture imbalance, this one, imbalance here, and epithelialization advancements. So let's start here by tissue necrosis or management of the tissues, or the T. I am here a ways of dealing with the wounds. My purpose is removing the physical barrier that will be create and base for the bacterial colonies. It will make the pressure, it affect the extracellular matrix, it keep the inflammation and the wounds irritation. On the same time, this unwanted tissues or the necrotic slough will make local source for oxygen, stop the new tissues from producing cells. And here, when you look for the wounds, and there are a necrotic in this ways, or if there is necrotic, so whatever the granulation here will come, and if this necrotic is already coming and stuck here, it will prevent any granulation to pass through, because there is space here, it's already taken. And now the space will be in a base for the bacteria and make irritation for the wounds bed. And this, so the management will make that we wanted to remove the deviated tissues, and that means we are removing the base for the bacteria and reducing the irritation that happen on the side of the wounds, and also it will lead for better chance for the wounds to heal, right? So now we already agree about the need to remove these tissues, either by what? I will remove, but how I will remove these bad tissues? The first priorities come if the wounds is healable. Let's take it in this way, that the healability of the wounds. We say that the people are much more affiliated for the surgical sharp debridement, which means we will use the blade and the knife and make it like in its ways of removing this undeviated tissues. And this is effective way because it's very fast if it's done in the proper way, and it will lead directly to eliminate the impact of the bad tissues. But there are some weaknesses or problems in using the sharp debridement in removing these tissues, such as the bleeding. It's needed special training. It can getting confused by some kinds of wounds that collect or the color of tissues between white and yellow. That means we are talking about tendon or infection or bad tissues and so on. So there are some precautions for the sharp debridement. That's why they opened the gate for a new researchers to say that what if we used a kind of mechanical debridement? What is mechanical debridement in this case? Instead of making the blade, what if we use the gauze or another type of dressing that will use as a wipes or another cleaning procedure? That when it comes to the wounds, we make the scratch on the wounds. So in this way, that we will just use normal saline and kind of dressings and make the scratch so the mechanical debridement will happen. While that studies developing in the mechanical debridement, they said, what if we used different material with this mechanical procedure, so this material can support the mechanical debridement. So they said, what if we used enzymatic component? So we will have a kind of solution, and then this solution will be used in the wounds while we are doing the cleaning. So we are making the mechanical debridement with the solution to make the enzymatics. Others say that no need to go for this harshment, because at the end mechanical debridement will harsh also the perineum area. It can also lead for the bleeding, so we did not get the proper ways. What if we use the autolytic debridement? What is the autolytic debridement? They say we should learn from the body itself. How the body deal with this unwanted tissue? They increase the amount of exudates. So what is the exudate are doing? The exudate by its nature, more than 80% of this exudate is just water, with 20% of something. So what if we create a material or manufacture material that can be used to adopt the condition of the body? In this way, we can support the body to remove it by adding material full of water with something else. Then the advancement happen in the hydrogel with its different types. The surgical debridement, as we are seeing or referring now, for two techniques or two famous techniques, either by direct by the knife or by a blade, or by using hydrosurgery, which is originated by VersaJet Hydrosurgery, Smith & Nephew, at the beginning, and now we have different types, or a lot of types for this hydrojet. I hope the video. Anyway, this is how it looks like. It's similar to the blade. This is the hydrotherapy. It's not blade, metal blade. Rather than it's a very fast flow of water, and this when the flow of water will pass through the tissues, it will lead for debridement. This is also how it looks like.
is a handheld device used for surgical debridement, in which a high-velocity stream of sterile fluid jets across the operating window and into an evacuation tube. VersaJet's Venturi effect creates a localized vacuum. This holds and cuts tissue while aspirating debris from the site. At its lowest power levels, VersaJet will function mainly as a vacuum and remove little or no tissue with each pass. As the power increases, VersaJet removes a greater amount of necrotic tissue and bacteria. At the highest power levels, the VersaJet system will remove non-viable tissue very rapidly and tackle all but the hardest eschars while preserving as much healthy dermis as possible.
So you can see here, this is one type of this hydrosurgery ways of making the debridement, but it's not the only one. I just like this video so it can be created or making clear for us about this. This is another type or another features for it, but it will show us how it already works. So this is by the actual application. So it will create removing for the bad tissues, and this is debridement. So we already reached to the management, the purpose of the wound care in managing the tissue and removing this bad tissues. You can see here, I hope the photo, the video to be clear, but in this way it make like a cuts, variable cuts over the tissues. Also, it's costly, it's not always available, and it's need a special technique because the flow of water can be painful if it's used or make injuries for the wound bed if it's not used in the suitable and the proper ways. Anyway, you can see here also how it looks like. And the wound care nurse or the surgeon can determine some factors in this machine before use it in the
يعني من الwound irrigation؟
فينا سؤال؟
بس اسال يعني هيك بالطريقه هاي نحن بنعمل الwound irrigation؟
لا مو irrigation، هذا شيء ثاني irrigation هنرجع عليه بعدين. هذا debridement.
اوكي.
debridement. اذا في عندنا الان احنا عشان ما تتوه معنا احنا حكينا الان انا في عندي الشارب debridement ماشي؟
هلا قلت لي هايدروسيرجيكال صح بتكون؟
ايوه هلا سيرجيكال debridement.
اوكي
تمام. هذه الشارب، هذه اول وحده، بعدين الهايدرو، هذه الهايدرو. So it's surgical.
اوكي. طب وليش سميناها هايدرو؟ لأنه بيكون فيها مي يعني؟
Yes, from the water.
اوكي.
هي high flow of water.
اوكي.
Anyway, the other methodologies or second methodologies اللي حكينا عنها، احنا حكينا على السيرجيكال، بعدين حكينا انه the problem in the surgical that there are side effects. Side effect في الشارب debridement انه انا بتعمل لي bleeding، فانا طولت المده تاعت الجرح، في عندي ريسك عالي، بدي competency، في عندي ريسك انه ممكن انا to remove different type of tissues، انه في يكون عندي tissues yellow or white. Instead of I thought this is unwanted tissue, but I discovered that it's tendon or bone or whatever. And we have الهايدرو surgery. It's also had some side effect اللي هي الcost, also competency, الريسك تاعها الى اخره. Then we go for the historical wise. Now we will make different categories for this one, which is the mechanical. إنه والله instead of doing this one sharp and so on, when I am doing already the cleaning for the wounds. In wound dressing in general pass through 3 phases. Now when you go to see wounds, you are removing the previous tissue and make the cleaning. Then you go to select the new dressing and then you fix it. So these are the 3 phases. What the people discovered in this way, إنه والله in mechanical, when we are remove the previous tissue, we already clean the wounds. So in this cleaning, what if we make mechanical ways of the wounds to clean it and make it in a proper way? So we can come here to put some solutions in the wounds, make the pressure irrigation in the wounds, not the irrigation for the moisture, but here we are adding solutions and make the movements or cleaning about it, and it will end by ways of mechanical ways. So we are either putting solutions started by the normal saline and clean the wounds by normal saline. Then what if we use the different materials, wound cleansers materials, and so on? Another problems appear. Now it's painful. Can also lead to blood. So we end by blood from our scratching or forcing on the cleaning. And this also will lead for another advancements happen or start by Edinburgh University, or what they call it ESOL. Instead of using solutions or normal saline, let's use material while we are cleaning the wounds. And the concept of enzymatic debridement. What if we use solution, and this solution will make or support us in the debridement, and then add after that another material or things in these solutions to make it used in as antimicrobial or antiseptic solution. The first people originated, or the first adoption happened for a kind of this solution, come what they call it ESOL, or Edinburgh University solution of lime, and they use it for, started to be used in the World War I for the soldiers were in the caves, and then this is how they use it at that time for the World War I, and they found that it's already suitable for cleaning and supporting the debridement by the enzymatic or chemical debridement. So in this case, we have now surgical debridement, mechanical debridement, and enzymatic or chemical debridement. We will put this on the wound and soak the wounds in, either by instead of making the mechanical debridement and solution, we will put this solution directly in the wounds and keep the wounds sucked in. So we will keep it above the wounds for a period of time. And they discovered that also there is another problems appear with this chemical materials, enzymatic materials, that it leads for a good job in removing the unwanted tissue, but it leads for another dead tissues in the peri-wound area. So we did not come to the suitable situation. The big advancement happened in the field of the wound care. It's creating the autolytic debridement. Autolytic debridement, they aim to adopt the same methodology that the body used to deal with the necrotic or slough, which is by splashing or making the amount of solutions in the wound bed, and this will make the works of breaking up or deviation, analyzing, destroying the necrotic tissue. And this is what they call from the autolytic debridement, then the creating of or application of hydrogel. Hydrogel, it's a type of dressings, and of course then the development happened in the polyurethane. Hydrogel, it's a kind of wound dressing that remanufacture the water to be in the wound phase, in the gel phase. In this case, it will lead for the debridement. It takes release in comparing to the another enzymatics, and it will also support in removing or debriding these bad tissues, and it's very selective because it works only on dead tissues. How it works only on dead tissues? The nature of hydrogel and the ways of transferring this gel to be in a water in the wound temperature will give a chance for the live tissues to adopt, but it will not give the same chance for dead tissues, so the dead tissues will start to detach. There are several theories and some assumptions happen on this way, and we will take it in its time about how they already create this hydrogel. But in general, just remember when there are a kind of biochemical material, مثلا food on a plate, and it's dry, so you will see if we put in water in it and keep it for a couple of hours. Then this biochemical material, the waters will invade inside, so it will expand it, so it will be able to detach from the plate. If we did not wash, for example, the plate or any biochemical material, such as food or whatever on the plate for sometimes until it's come dry. So just add the water, then the water will be able to take it out. The development happened and the kinds of the hydrogel, they said, okay, so what if we used another enzymes with this hydrogen? So they call it advancements happen in the enzymatic debridement by using the same gel and we add something else with it, such as collagenase or papinuria. Subhanallah, يعني احنا في القرآن we have a story of Quran about the Prophet the Nun, that already when he stuck in the mouth of the hut, the fish, and he stayed there, then when he kicked out from the fish, then the order comes from Allah that to be near an yaqtin or papin plant, because its impact as an enzymatic protection for these bad tissues and supporting for the new tissues to be removed. Anyway, there are a lot of talking about the enzymatic debridement, and there is also additional advancements happen in the wound care with the new products, but there are some limitations, and these limitations associated by the patient's readiness for these enzymes to come, the allergies and so on. So still there are debates around it in the part of the wound care. But when they analyze the effect of enzymes, how it's already these enzymes support in making the tissue management, they start to think if there are another source of these enzymes and its impact on the wounds. And then here we come to the biological debridement, or the larvae of a green butterfly or a Leishmania sericata, which is kind of maggot under specific situations or specific preparation. They will put this maggots in the wound, and this maggot will take time until it will eat the unviable tissues, and the saliva that come from these maggots will support also in the debridement. So it will help in both ways, in enzymatic and mechanical, and it will be selective. Anyway, there are several debates about the biological debridement, but now start to get more acceptance about its role, not only as a tissue management or in tea, rather than also in its role in biofilm management, in biofilm treatment, and in the MRSA, because of its role in destroying the connections or the pockets that the MRSA will keep on. And this also, we will have inshallah a special lecture for it, but here just only, as we said, the panorama overview about the thing. So in the wound bed preparation, based on that, what is the debridement of the tissue management? We are aiming to remove the necrotic tissue, exudates, and the base for the bacteria that will stop the wounds from healing. And this is the mechanical or methodological way that there are several negativity of having this these tissues in the wounds, and it will lead for this basic for the bacteria and stop the normal wound healing process. Okay, then after that, the debridement. Another important for us here to determine what are these unwanted tissues. So based on what we will come to say, oh, this is dead tissue or this is necrotic tissue. There are several suggestions within this theory to support the practitioners to determine or identify the unwanted tissues. Firstly, and simplicity, by its color. So we can say this is black tissue, and the black tissue most probably refer for necrotic. Yellow tissue, this is most probably referred to slough, and so on and so forth. The green mean this is slough with a Pseudomonas, or the type of bacteria that come create this green, or maybe gray, or maybe slough with blood, and so on. So they start here to take ways on techniques for the practitioners to determine. For example, in these tissues, what you are seeing here, this is the peri-wound area, right? So this all the في سؤال في أحد السؤال رامية you have a question طيب هلا هنا عندي أنا البري-wound area صح؟ This is the peri-wound area and you can see here the signs of cellulitis. طيب this is the wound edge, right? Now we are talking about what are the type of tissues we are seeing inside the wound bed. Here they say first determine the color. So what you are seeing here, white color. Here, yellow color. Here, necrotic. So they start here to define the type of tissues based on how these tissues already died. So for the necrotic tissue, the amount of dead tissues happen suddenly for a large area, and it's happened with absence of oxygen and absence of blood. So directly the tissue is converted to being blood. While by chance here for the slough tissues, you can see that this tissue is passed. We have here a question. Oh man, no problem, no problem. You can see here that this tissue is already yellow. That means also there is dead tissues, but this dead tissues happen with the presence of oxygen and blood. So these slough tissues are connecting bad tissues with white blood cells and the enzymes. So this one will be much more moist in balance comparing to the necrotic tissue that will be hard. And there are here the white tissues, which can be in a fibrin. And fibrin means this is in a dead muscle tissues, but still it's not infected, or the bacteria did not build a base on it. In this way, they start here to make additional skills to identify the necrotic tissue based on the color and the characteristic, as the necrotic tissue should be black, hard, and immovable, or the movability of the necrotic tissue because of the base and the dead tissues. When the necrotic tissues start, or the back tissues start to be moved or flexible or moving around, so the slough start to originate it down, and that means the white blood cells start to work. And this is what this screenshot of the original guidelines, and it's already described here. The yellow tissues referred to as a slough, and they differentiate between the yellow tissue and the necrotic tissue, or yellow tissue and the black tissue, based on its originality of development. And in both cases, each one already had its own characteristic and its impact. I hope the photo is already clear for you, but here you can see this is slough tissues. This is also the slough tissues. Here we have the granulation tissues, and you can see here this is bad unwanted tissues can prevent this granulation to swim on, and even for the keratinocytes to stay and progress in the wound. So we need to make debridement. Another recommendation comes from the theory that heal debridement is questionable and the big issues in the wound bed preparation. In the famous expression, they use it in the word of wound care, heal, never heal. And this is about or related to the nature of the wounds in the heel. So we will take this in consideration while we are dealing with a sharp or mechanical debridement of the heel. For the sharp debridements, now the new trends, the trends that if the wound care nurse will do the sharp debridements or the blade debridements, they need to take the privilege. And this is not a competency anyway in the field of the nursing and the epistemology. There are differentiation between the competency of the wound care, that what we discussed in the beginning of the diploma, and the privilege. And this privilege, it's come from the surgical domain. So some of the surgeons should train the wound care nurse to make this sharp debridement to be in a legal and methodological issues. And this is supported by the wound bed preparation. That there is no doubt about the ability of the wound care nurse to do the sharp debridement if they pass through the privilege and it's not a competency issue. And also, we don't want to have this this base or these problems related to the wound care practices. Another ways or issues in the wound bed preparation for the stable healed scare or a scar in the presence of untreated peripheral vascular disease should not be debride. So this is what's written in the guideline regarding to, as we said, in the healed debridement or the wounds in the heel. This is need to get special consideration before going for any sharp hydro or mechanical debridement. But there is, of course, no problem to use the hydrotherapy or hydrogel or autolytic debridement. Also about the exact or the marks between the viable and non-viable tissues, mainly on the foot, on the diabetic foot, either on the pressure ulcer, when the toe already getting demarcation, so the marks between the bad tissues and the healthy tissues start to appear. There is also another recommendations or talking about the safe space in the diabetic foot, until when the debridement will happen or the amputation will happen. And even the amputation, it's a kind of debridement. So this is all important points for us to take it in consideration. Right. In this way, now what is the next after we talk about the tissue management? So we will go for the eye management, and this will be also a long topic. I don't want to lost you in the middle about the details, but in the same way, I should use the material that will be an antimicrobial, so it's not antibiotic. In general, in the words of pharmacology, they differentiate between antibiotic and antimicrobial. In antibiotic, we are talking about a chemical material that will kill a bacteria by using specific way. So we will see in a material antibiotic that kill the bacteria by destroying the cell wall. Another kind that kill the bacteria by destroying the replications or the DNA. Another ways that kill the bacteria by preventing this bacteria from multiplication and so on. And this antibiotic in general are selective. So you can see an antibiotic that's suitable for gram-positive, for example. Another antibiotic suitable for gram-negative, or maybe some here on the bacteria. But it works on the bacteria, don't work on the fungus. Work on the fungus, do not work on the virus. In the wound care, we have a collection of all. So we have a bacteria gram-positive, we have bacteria gram-negative, we have fungus, so we need antimicrobial. That's something that's able to deal with all of them. So this is the infection management. And the infection management, we will start to be with the key stars of material called silver, and we're talking about the ionized silver. Ionized silver can kill the bacteria, can kill fungus. Unfortunately, also it can be toxic to the body, so it's not recommended to be used in this way. In the infection part, we will know that it's now not recommended at all to use any local antibiotic in the wounds, as this can lead for the patient to get immunized against this antibiotic, and this will support more the resistance of the bacteria and so on. After that, then they will go for the moisture, and in the moisture balance, there are different sets of products that will aim to make the balance on the moisture phase and supporting the epithelialization in there. After that, now again, as I told you, we will take all these letters in detail. So this is just a panoramic overview. So we will make in consideration what we are going or how we will deal with these things. The other ways, after we finish the time, we will go for another challenging point, which is the discipline. Okay, so I know now I will use hydrogel, for example, with a silver. But when I go to the actual condition on the store that I have it in the hospital, or I will refer the patient to specific kinds of products, there is a cohese, because there are different available or different options and different challenges that face the clinicians about which is the most suitable products based on the wound bed preparation principles. So of course the cost will be the principles, the customers themselves and the availability of this one, the policy and the procedures in the hospital that you are working on, quality of life and usability of these products, and to which extent you are familiar and comfortable in using on these products. We cannot come now to take these decisions until we understand the principles and how the would be the preparation, arrange the priorities for us. So the priorities will be on the T on a specific flow, for the I also on a specific flow, and so on. In general, the evidence about the best wound care products for the wound healing and prevention, it contains the ways of our understanding for the biological and biochemical components, and it's no longer related to the wound itself. While there are other entire human factors can help us to determine what are the most suitable products that we will use based on our understanding for the time. So in our responsibility here, we will close the gap of how we will go for the most suitable wound care products. We'll be able to target the audience of the patients in need for this product. And of course, the cost is a priority, and we will go for an easy to use. Until this level, don't go for any product that you don't know about it. Try to read the principles and make sure that you're able to put this wounds or housing. We call it now housing. Housing, in Arabic means taskin. We are able to put this wound product under which category within the wound bed preparation. So I will be able to determine and assure the usability of the products in the wound. On the same time, there are also additional talking happening in the environmental principles about the waste products or the waste of this, or after we use the wounds, then we will go it for the waste. So from the infection control perspectives, and mainly they're talking about the silver and the components that use the silver. The treatment decision that we will use it, we would like to think in a products that will minimize the trauma to the wound bed, eliminate the dead cells, the dead space, assess and manage amount of exudate, support the tissue defenses mechanisms, and of course we are going to less toxicity in the wound cleansers. Now here in the slide, used non-toxic wound cleanser, but now the guidelines said about less toxic wound products, remove the infection barriers, environmental maintenance, surrounding tissues, and this is also paraphrasing of how the decision can be done based on the eye and the antimicrobial dressings, and this is the NICE guideline for dressing selections about which type of products can be used or which category of this product. We are not talking about commercial products here, rather than we're talking about the scientific description of these products, because under each scientific descriptions, we will see also variations coming from the commercial point of view. Anyway, we are looking here to determine, or we will not mention any commercial ways of the products, but we will describe in some cases the uniqueness in the scientific description of each product. So when we talk about the hydrogel, we're talking about more than 15 kinds of hydrogel now we have in Jordan. Maybe some originalities come or uniqueness, tested ways, and it's a way of how we will provide benefits for the organization where we are working, hospitals, healthcare facilities, and the people we are taking care of. And at the end, this is rate of return to the whole community and society. So at the end, this is connected with the economics on these ways. And now the wound bed preparation, it's getting welcomed in the field of the pressure ulcer, pressure injury, the hepatic foot ulcer, surgical site infection, and other wounds such as oncology-related wounds, burns, foot ulcer, and so on. But in some of these wounds, there are additives. So during these modules, we will focus on the time as it's time. But when we go to the pressure injury, we'll say, okay, this for time, there are additional points we should take it in the pressure injury. And when we go to the diabetic foot, we'll say, okay, as the same what we add in the pressure injury, there are another points we should consider in the diabetic foot. And there are also another points we will add it for peripheral arterial disease, for the vascular insufficiency disease, chronic vascular insufficiency, and there are another points related to the burns, another points related to surgical site infection, but all it will rely on the basic of our understanding for the wound bed preparation. In general, there are logical fallacies, يعني مغالطة بالعربي, about or the trying in the wound bed preparation to prove its wrong way, that all the wound care products are the same. We have now a strong evidence that not all the wound care products are the same. They are not the same in efficacy, they are not the same in the time of using, they are not the same in its impact on the wounds, and so on. So this is important to take into consideration. Why? Because before the wound bed preparation, the people, they said any gauze and water and hydrocolloid or kind of dressings are all the same, so no need to bother yourself to see if this one's necrotic or not, all will work the same. After the wound bed preparation, this starts to be a fallacy. Our concern here to reach at the end by this training that we are able to choose the most suitable dressing for the patient's condition. And it's not easy, it's not hard, rather than it's impossible that we can support our ways and mindset until we will be able to determine the right decisions. After the wound bed preparation, several theories and hypotheses already try to rely on this systematic approach and try to give ways of describing or classifying when I will start by this product, then when I will go from this product to another product, and so on, and why this has happened. So we will discover these theories and the rationale behind this, and why the wound care products developed after the 2003, and then the advancements happen in the kinds of dressing that we have it. In general, the healing and treating the wounds, it's an important points that we should consider. The take-home ways measure that today we take a panoramic overview about the wound bed preparation. So we know about the tissue management, infection management, moisture management, and lipphalization. So for example, for the tissue management, this is an example of how the tissues look like. At the end, these wounds cannot be healed if these unwanted tissues or viable tissues already appears on the wounds. So in this case, I will ask here, what are the kinds of products that's available in my hospital to deal with this one? We will hear about the hydrogel. We will hear about hydrotherapy. Important here to differentiate between hydrotherapy and hydrosurgery. Hydrotherapy, it's a kind of dressings that now available in market, will be in a bag, and this bag soaked with Ringer lactate or normal saline, and it will keep continuous releasing on the wounds and also absorb this, absorb the waters again. So it will make in a cycle of dressing. So this is different than the hydrosurgery. This is hydrotherapy, mechanical debridement, enzymatic debridement. Now the different classifications and how I will follow the classes of or flow. So I will use, by for example, hydrogel. Then until when I will keep the hydrogel before I will go for hydrotherapy, for example, and so on and so forth. At the end, the decision that it's not only based on the scientific evidence alone, but also on your capabilities, availability, and the abilities to follow up the organizational policies and procedures. This is an example of the hydrotherapy. For example, there are products called HydroClean Plus, which is already used as an examples of developing the understanding of the impact of the hydrogel, or when we are unable to use the hydrogel, for example. There is also another product which is protease modulating polysaccharide-based hydrogel, which is hydrogel added to it some enzymatic components. And when I will you go for this one, why I should go for this one, not for the normal hydrogel. So this is what we were going to discover. I know now the amount of information that you heard and listened for it today. It will be a little bit confusing or maybe hard to be digested in one day. So this is, as we said at the beginning, this is just panoramic overview. So we will go for each of these letters alone, one by one, tissue alone, infection alone, moisture, and so on. Now, what I should do until now, I hope that you will be relaxed about this information and make sure that we are following the scientific evidences and the ways that describe the nature of the ways of decisions and practices. This is, for example, Ministry of Health in Malaysia. I like their own frequent guidelines about technologies, and they try to help their own staff by determining exactly when they will use these products and based on what, and so on. Anyway, we are not relying on what's already adopted or available in Malaysia based on their own ways or the availabilities, but with the flow of events that can be helped us. For example, in the debridement, they said directly the first decision will be that you will go for hydrogel, and you will keep for the hydrogel until either you reach the first 14 days or 28 days, or the wounds transfer to be exudates. So in case of exudates, you should stop the hydrogel, or after 28 days of hydrogel, then you will go for hydrotherapy if the debridement is not an option. So this is the ways. This is an example for the wounds in the infection management. And they said here in the infection management that you will go for the silver, and then the silver, you will determine that we're talking about ionic crystalline, ionic non-crystalline releasing silver, and then again you will use it for 14 days, then after that for 28 days. If the wounds did not get any spots, so you should stop. So no more silver than 28 days. Before that, you should check there is no exposed bone, there is no exposed tendon, there is no bleeding. Okay, after 28 days, the wound's still in this way, so you will go for honey, or you will go for PHMB, or you will go for iodine, and so on. So we will determine what are the guidelines talking about it, and let's need again ways of explanations and taking about it. For the silver, we'll have a special lecture for silver because there are now huge debatable issues. What happened in 2017, the insurance in Germany and followed by the Belgium and Netherlands and some insurance companies in French, they said that we will not reward or reimbursing the silver when it's already used on the wounds. They said about some reports about its impact, the environmental factors and the waste dealing of the silvers, and the debates about different types of silver. And this making a debate, a huge debates in the field of the wound care, while still in America and Canada, there is no any of this debate. So we will talk about this debate. Then the new trends were coming back again for the honey dressing, the BHMB, so this is boy. So the BHMB as a replacement comes from Germany to try to minimize the negative impact of the silver, and the iodine dressings and so on in this way. Then we will go for the moisture management. We will discover the techniques and the type of products that either absorb and keep the fluids as hydropolyurethane foams, or the supra-absorbent materials that will transfer the fluids to be in a gel or a different nature, or maybe the negative pressure. We'll talk about the alginate and the types and what are the additives happen in the alginate, the hydrofiber, what are the differences between them. Then the negative pressure wound therapy, it's already come in this ways, and the epithelialization. Here, before the epithelialization, there is an important and debatable lecture about the skin care. So we will talk about how the skin already built and protected, the role of cosmetics. Now the cosmetic is not an option, so we will deal with the impact of this cosmetics and the shampoo and so on the skin before happening the wounds. The decision that will the people followed up, there are suggestions called the hypo behavioral theory in how the wound care can reach to make the actual behavior in the wound dressings or in the dressings for preventions and so on. There are several updates happening in this theory, but in general, this is how we think about our ways of making or selection. There are, of course, kind about our beliefs in the ways and the assessment. There are normative beliefs and there are control beliefs. This control beliefs can be like a policy on the procedure. This will lead for our attitude toward the behavior, what already the environment around us accept, and also what other organization will lead us until we will use intention for using or selecting a specific product, and then we will use this product or not. And there are several issues. The biofilm also will take a kind of focus on the infection bar because of its impact and a ways of how can manipulate our decision in the wound dressing selection. The wound Senium, they already published this management of biofilm, and it's free available position document, and they here expand the infection status related to the biofilm and how it can affect our decision in the wound care. This is, and for example, and apart from the techniques about making the sharp debridement, and this is me in the video, so you can see, for example, I'm not advising you on this level to try the sharp debridement until you take the privilege from your institution or your hospital.
Give me this case. Okay. Just dermacine or Borodine. Now today we'll have a case of, yeah, just put it here, please. On the bed debridement. Thank you.
So here, in this dressing, that we are using this wound cleanser material to support us as enzymatic debridement. Support us, but still I can use the normal saline in this procedure. But if I am available or able to reach the enzymatic debridement,
For this stuff, the patients already complain of fourth stage pressure ulcer. And we are now in the stage of doing tissue management. How we can differentiate between the healthy tissues and dead tissues when you come to touch the
الصوت مسموع. Do you hear the voice in the video? الصوت مسموع من الفيديو ولا لا؟
the dead tissues, it will come for you, it will be elastic, and it will come to you that's it's not tight to the skin. Also, that smell here there. Secret video.
Okay, this is how we can do the sharp debridement. Chemical strategies, ionic silver, whatever, the honey, how it looks like. This is the third 3D imaging for infected wounds. You can see the distribution of the cells and so on. So this is in general, this is for some other additional information for the biofilm and how we will deal with this waste. In general today, the take-home message that we already consideration the ways or our strategies in dealing with the wounds, how we think about the decisions that supported from us from the wound bed preparation, and this will be again a panoramic overview. So you know there will be additional taking in details about these points related to the wound bed preparation. In general, the wound bed preparation is the new theory that leading the care and the research fields in the field of the wound care. It's originated to support us in systematic overview, and it will be under the abbreviation of TIME after classifying the wounds for healability and non-healability, tissue management, infection management, moisture, and utilization, and we should pass it through it in systematic way. So I cannot focus on I without assuring that I am in a suitable condition for the tissue and so on. And so, is there any question? في أحد عنده سؤال أو استفسار؟ Any additional points?
يعطيك العافية دكتور.
الله يعافيك يا رب.
دكتور بس ممكن استفسار. أنا as a wound care specialist في critical unit area. كثير patient بيجوا لعنا أصلاً من البيت at home pressure injury second degree and third degree. When we do sharp debridement or in surgical debridement, improvement will when we do follow up to this patient very slowly. also patient on ventilator. كل هاي أكيد بتأثر على الwound healing process as oxygenated. يعني أنا أمرات مثلا خلص بخلي البيشنت conservative simple dressing لأنه I can't do anything to septic shock. This right?
طيب هلا يعني سؤالك يا شرف العافية إيمان، سؤالك كثير جميل في مكانه. At the beginning here, Iman is asking about the condition on the critical care and when we are doing the sharp debridement, so the impact on the patient's worst or the patient's progress is less. صحيح أنا هيك إيمان فهمت الموضوع. First one, Iman, we should able to differentiate the healability of the wounds. Now, based on this condition, maybe the wounds that you are dealing with is unhealable wounds or stagnated. In both cases, we will not go for sharp debridement. We will go for conservative debridement because our priority is to stop the progressing of the wounds. So you can go for hydrogel, for example, and for the wound antimicrobial dressing, you will go for iodine or PHMB. So you will not go for silver in the non-healable wounds and so on. فكلامك صحيح. إذا كانت حالة المريض أصلا في الانهيلابيلتي، أنا البريورتيز تاعتي إنه هذا الجرح ما يوصل فيها إلى مرحلة الديتيريوريشن كواليتي اوف لايف او البروجريس على حاله المريض. لكن اذا كان في عندي احتماليه الهيلابيلتي وعندي بيشنت كونديشن في الهيلابل ويز بروح للشارب ديبرايدمنت. تمام؟ حتناقش فيها ان شاء الله هذه بالتفصيل اطول خلال محاضرات
ان شاء الله. ثانك يو دكتور.
شكرا جزيلا لكم. في احد ثاني من السؤال واستفسار؟ سبحانك اللهم وبحمدك اشهد ان لا اله الا انت استغفرك واتوب اليك. ثانك يو فيري ماتش. هذا الدكتور عبد الكريم بس فيكم ونستودعكم لنا ونراكم ان شاء الله الاسبوع القادم. السلام عليكم.
Recording stopped.